Hello and welcome to the Oncology Podcast, an Australian oncology perspective. For more info and to sign up to our weekly newsletter, visit our website oncologynews.com.au. Thanks for listening.
Hello, this is Rachel Babin. Welcome to another edition of the Oncology Journal Club. This week, Professor Eva Segelov from Melbourne, Australia, gets us started with a presentation on the ASCO Value Framework and ESMO Magnitude of Clinical Benefit Scale. As usual, she is joined by Dr Craig Underhill and Professor Hans Prenen. Hans chats with the world-renowned Fotios Loupakis from Italy on the latest GI updates and also gives us his quick bites. And Craig presents two fascinating breast cancer papers. We hope you enjoy another entertaining and informative episode of the Oncology Journal Club. As ever, the links to all of the papers discussed today are available in the notes. This is Rachel Babin, and this is the Oncology Podcast.
We're on the air. Hello and welcome to episode number 6. I'm Eva Segelov.
And I'm Craig Underhill.
And I'm Hans Prenen.
No, you stuffed it up. You just had to learn your name. Let's go again. I'm Eva Segelov.
I'm Hans Prenen.
And I'm Craig Underhill.
Great. So today we have an exciting program for you. We're coming out of ASCO analysis and back into some interesting, quirky, different papers that have been published, things that will affect our practice, and things that it's just really good to know about as an oncologist. So first up, we have a paper that I'd like to present entitled Application of the ASCO Value Framework and ESMO Magnitude of Clinical Benefit Scale to assess the value of abiraterone and enzalutamide in advanced prostate cancer. This was published in JCO Oncology Practice earlier this year. I'm going to present the results, but really the reason I've chosen this paper is to give us a chance to discuss the ASCO Value Framework and the ESMO Magnitude of Clinical Benefit Scale. So if you're very familiar with these, you can fast forward the episode. Otherwise, stick with us. So this paper is based on the premise that agents such as abiraterone and enzalutamide are moving into earlier stages of treatment. And for men with advanced prostate cancer, they are often therapies that are used for many, many, many months. And this has significant cost implications. So in this paper, they use PubMed to identify 8 randomized phase 3 trials. They applied the 2 different frameworks. They found slightly different results, as you may expect, from 2 different frameworks. But the principal finding was that when administered in earlier disease settings, both drugs do not necessarily provide consistent increases in incremental clinical benefit. However, the costs increase enormously, mainly because of this increased treatment duration. And it raises the issue of optimal sequencing of therapies, both from a clinical benefit and a cost perspective. So what are these scales? Because you're only as good as your measurement is. Are they really something useful, or will they always tell us that using drugs earlier is more expensive? We all know that. How do they help us? So the ESMO Magnitude of Clinical Benefit Scale was first published in 2015, and it's a standardized, generic, validated tool that tries to look at the magnitude of clinical benefit that can be anticipated. So it looks at the observed benefit that the trial reports, OS, PFS, quality of life, and toxicity, and it compares like studies, which is one of the limitations of both of these scales. And it's restricted to randomized or comparative cohort design trials or meta-analyses. Now, the original idea was to assist both the original oncologist sitting with their patient explaining the likely benefits of a particular treatment, as well as to aid public health decision making with this sort of general social responsibility that we all have for prescribing increasingly expensive therapies. However, I would say that that first objective has not really been used, and very few people do I know that restrict their clinical practice according to the magnitude of benefit scale. But ESMO states it has a public commitment to present, quotes, clear and unbiased evaluations of the magnitude of clinical benefit, end quote, as a matter of important public interest and professional integrity, and they undertook to use their scale to all new drugs approved by the European Medicines Association. And they said they'll use the pivotal published clinical trials to make their assessment, and they would update their assessment as more data became available, for example, OS data, where previously PFS was reported. But already you can see a bias if you only present the published trials and you only select what you deem as the pivotal trials. So the MCBS is a score between 1 to 5. Scores of 1 and 2 are low clinical benefit. 4 and 5 are substantial. If you have the primary outcome being PFS, you can only get a maximum of 4. And if you have OS, you can go to 5. So ASCO has undertaken 2 different initiatives to try and promote the value of cancer care. A working group that proposed thresholds for the approval of cancer medication based on modelling for 4 common conditions: metastatic colon and breast cancer, non-small cell lung cancer, and pancreatic cancer. And they proposed thresholds for meaningful clinical benefit improvement in terms of minimal increase. What would be the minimal increase in benefit that we would think would make a new treatment of clinical benefit? And they recently published their thresholds. It's a score that ranges from 0 to 180. An AVF score of less than 40 is low clinical benefit, and more than 45 is substantial. Now, they also have a value in cancer care task force as part of ASCO that's looking at working on refining a framework for evaluating value in oncology. So what issues does this paper bring up when applying these frameworks to the use of ABI and ENZA earlier in prostate cancer? The first point is that not all papers publish all the parameters that these scales rely on, in particular missing quality of life data or limited reporting of toxicity. Now, ESMO responds to this saying that this should encourage trials to include and report quality of life data. But this is a limitation. They can be analysed but not get a higher score. The other thing is that this ESMO scale does not consider the heterogeneity of patient populations. It assumes all patients will have similar benefit from a treatment, and it assumes the magnitude of benefit is the same regardless of the type of cancer. It still doesn't help us extrapolate data from trials into the general population, and they're now racing to include new endpoints such as PathCR for neoadjuvant studies as surrogate outcomes. So we still have a way to go before we can find a scale that is useful, let alone agree on what the thresholds should be for bringing new treatments forward. But an interesting paper and really worth being familiar with these concepts of clinical benefit and value frameworks. All right, Craig, wake up, hands. Any questions on that?
Actually, it was very clear, Eva. I completely understood it.
Thanks, Craig.
Hans here. Eva, how does this system of evaluation differ from what currently happens with the PBAC in Australia?
That's a great question, Hans. You've got a good knowledge of Australia. The PBAC make recommendations based on cost effectiveness. And it's really important to understand that. So effectiveness, how well it works, is quite different from cost effectiveness, for which they mainly use QALYs as far as I understand, quality adjusted life years. So this is a problem for drugs for very rare diseases where they may be highly effective but incredibly expensive. For example, children with inborn errors of metabolism who can be cured by having an enzyme, but there are perhaps 20 children in Australia who need these. So they're considered outside of that system because for them, cost effectiveness, they are highly effective, but they're never going to be cost effective on that model. For our cancer drugs, generally they are used at cost effectiveness. And of course, cost is a mobile phenomenon. And we often see companies negotiating whole packages of drugs. Some of the surprising inclusions on the PBS have come not because the drug may be so effective, the anti-cancer drug, but they were thrown in with a bunch of statins or other medications for other diseases as part of a package, and that brought their cost into being in the cost effectiveness range. Now, I'd like to ask Hans, how does the funding work in Belgium or more generally across Europe?
Actually, in Europe, it's different in each country. So first of all, you need approval from a drug from the EMA, so the European Medicines Agency. And once it's approved, then each country can decide for their own if they reimburse a drug based on the efficacy of what they think is worldwide giving to the patient. But it can be that the drug is reimbursed like in Belgium and not in the Netherlands, or it's in the UK. In most cases, Belgium reimburses quite a lot of drugs in general.
So do you see a lot of drug tourism for that reason? People coming across, be very easy to go into another country in Europe and get a drug?
Actually, they do, but there you have an insurance problem, because if they come from another country and they don't have Belgian insurance, it means that the insurance from their home country should pay for it. So it's not a Belgian insurance, but from the Netherlands, for example, a lot of patients are coming to Belgium because we sometimes give drugs that they don't apply in the Netherlands.
I think in the case, Eva, of these two drugs, though, there are some subtle differences, and it's actually good to have both available as options. So I wouldn't want to see this kind of study really meaning that there's only one option available. So sometimes it's good to have both options available because you can tailor the treatment according to patients' comorbidities.
Absolutely. The only problem with that is people tend to think they cost the same. So this is a nice way of pointing out if there really is a major difference between the two in actual cost to society, not to the patient, then that is something that I think we as a group of oncologists should be aware of. So let's jump into some other breaking news, some interesting data still catching up from ASCO and related publications. And Craig is going to take us through two key papers relating to treatment of breast cancer. The first, HER2-positive breast cancer, and the second to do with breast radiation. Thanks, Craig.
Thanks, Eva. So I picked a couple of papers that might have some clinical applicability to balance out some of the more maybe left field papers that we present on this podcast. So this is a paper published in April in Lancet Oncology, and it's abimaclimab. Say that again. How do we say it?
I think it's abimaclimab. It's a good point.
You're the native English speaker, so you should know. It's abimaciclib.
Abimaciclib. Okay.
Abimaciclib.
No, abimaciclib. It's a Dutch word.
Is it?
No.
1 point to you.
So this first paper was published in Lancet Oncology in April, and it's abimaciclib plus trastuzumab with or without fulvestrant versus trastuzumab plus the standard of care chemotherapy in women with hormone receptor-positive, HER2-positive advanced breast cancer, monarcHER study, a randomized open-label phase 2. So the reason for picking this is, I guess this is an unmet need. This is in a population of patients who failed at least 2 lines of anti-HER2 treatment with advanced breast cancer. And then often we're looking for treatment options in this patient subgroup. So in this study, patients were randomized to receive investigator's choice chemotherapy plus trastuzumab, or the combination of that abiraterone plus trastuzumab and fulvestrant. So the fulvestrant is not yet available in Australia on the PBS, but there is a significant number of patients who do purchase it through an access program because it's not too overly expensive for them to pay for the first few months of treatment. And in this study, there was a significant disease-free survival seen for the combination with the fulvestrant plus the abiraterone. So I think it does give us another option for treatment in this population. So people can click on the link to see some more details about that paper. So the second paper will cause some controversy amongst our listeners from the radiation oncology world, because it's a paper entitled Hypofractionated Breast Radiotherapy, and I'm sure ears are already burning. So hypofractionated breast radiotherapy for 1 week versus 3 weeks, 5-year efficacy and late normal tissue effects results from a multi-center non-inferiority randomized phase 3 trial. So this was a study done in the UK, and patients were randomized to receive adjuvant radiotherapy for their breast cancer, and they received either standard 3-week treatment, which in Australia is probably not standard because many patients receive more than 3 weeks, versus 1 week of radiotherapy. And what they showed was that this was non-inferior with no difference in outcomes, both in terms of efficacy and side effects. So this really builds on a large body of evidence that shows that conventional versus hypofractionated schedules really doesn't appear to have any difference in breast cancer specific survival, 10-year mortality, breast appearance, late radiotherapy toxicity, or decrease in acute radiotherapy toxicity. And so there's been 2 meta-analyses looking at these issues. So I guess, as I said, it really builds on the body of evidence that this, again, is probably a treatment option for patients and has some major implications in convenience and resource allocation for patients, probably especially in less developed economies than our own. Just a question though, so why do you think it is that we haven't switched over to hypofractionated schedules? Do you think there's still concern about late effects?
That's actually been studied, and perhaps we can present some data on that next podcast. There's many reasons, and the elephant in the room is the financial incentive, with payment per fraction persisting even despite the Medicare rebate review. So we know that the uptake of 3 weekly standard adjuvant breast radiation has been less than we feel it should be according to the criteria of patients studied in the trial. And going to 1 week would be major advantage. Let's see the impact. And we might even find a friendly radiation oncologist to bring on next podcast and ask that question. If anyone is out there and listening and wants to volunteer, contact us. And now for our interview of the week. And this week, our roving reporter, Hans, went to interview our very good friend Fotios Loupakis, who's Professor of Oncology in Padua in Italy. Fotios has been to Australia on a number of occasions and is a real leader in the field of GI oncology. And more recently, many of us saw some of the videos he sent in the height of the coronavirus epidemic, where he was reaching out because he had so many messages of people asking him how he was and how he was going. We asked Hans to ask him about Beacon and other important GI updates from this year's ASCO.
Hi everyone, it's my pleasure to introduce you to the world-famous oncologist Fotios Loupakis, and also a very good friend of mine. And I will interview him today about the role of BRAF in colon cancer. And if you think that he sounds a bit tired. This is completely logic, as he recently became for the second time father. So, Fotios, how is it going with your two kids?
Last time that I slept 2 days ago, I was fine. Now today
Okay.
I'm a little bit tired, but no, I'm joking. The newborn is really fun and is doing great.
Okay, good. So you published quite some articles on BRAF, so it's already for quite a while. First, we thought that we should give chemotherapy, quite intensive chemotherapy for BRAF, together with anti-angiogenic agents or not. But maybe let's start with the beginning. So we always speak about BRAF mutant colon cancer, but is there one type of BRAF mutant? And I know the answer, but what do you think of how can you explain different types of BRAF colon cancer?
Thank you for your question, Hans. I think you think you know the answer, but probably you don't. As me, we don't know the exact answer. What we know is that things are much more complicated than we thought before. There are two levels of complications. First of all, when we talk about BRAF mutation, is not always the BRAF V600E mutation. And this is very well described, especially in melanoma, but also in colorectal cancer. There are works, especially coming from New York, from the Memorial Sloan Kettering, giving us a lot of information around these differences and the classification of BRAF mutation in at least 3 distinct classes. But as you know, there are also intrinsic differences, so intragroup heterogeneities, among BRAF V600E colorectal cancer. So it's a category with different subgroups inside. And this is on the molecular level, but also at the clinical level.
Yeah, because within the V600, you published a study which was called the BRAF B-Cool study. I don't know who invented that name. Was it you?
Let's say that I gave birth to that name with a very close friend, Dario Ribeiro from Turin. So thank you for asking, because this is a nice opportunity to thank Dario for the nice questions and answers that we have on the topic, and then we came up with that name.
Yeah, because within that study, and that's something that I like, is you look more at clinical parameters. So maybe you can explain very briefly what the BRAF B-Cool study showed.
Yeah, what we wanted to explore is whether BRAF is a kind of original sin that patients and tumors have, and they are badly assigned at the beginning. So that is a negative prognostic marker, absolute negative prognostic marker, and it is not. There are some patients with limited disease presenting with not many organs involved, presenting in good clinical conditions, that may behave differently even if they bear a BRAF mutated tumor. And that is independent of MSI status. So having or not a deficient mismatch repair status plays a role, especially in terms of therapeutic implication. But these clinical features that we described in the paper drive the prognosis of these patients. Having a small subgroup of 10 to 15% of patients with life expectancy that is similar to non-BRAF V600E mutated patients.
Okay, so this is on a clinical level. It's all within the BRAF V600. But can you give some advice? Okay, are there any clinical parameters that we should take into account when we decide to start a treatment in BRAF mutated colon cancer?
What I would suggest is not considering upfront BRAF mutation as a bad prognostic factor if you don't consider the scoring system that we proposed, at least the so-called simplified scoring system. What we included in this prognostic score is performance status, CA 19.9 levels, LDH levels, neutrophil lymphocyte ratio, grading, and also sites of metastasis, liver, lung, and nodes. Based on these parameters, you may come up with a different prognostication for these patients with a life expectancy that goes from 6 months for patients with a so-called high risk to 30 and more months of life expectancy with patients with a low risk.
Yeah, and you were co-author on the Beacon trial, I guess, with targeted agents in BRAF mutated colon cancer. If you would choose, would you start in every metastatic disease now with targeted agents rather than chemotherapy? What would be your choice?
Again, a very burning question for clinical practice. We know that the Beacon data derived from a population of patients that was progressing on chemotherapy. So from a methodological perspective, and also being really evidence-based in our practice, the proposal for BRAF inhibitors should be restricted to these patients. So progressing on at least one line of chemo. There are trials ongoing, so I think that, and I hope that good news will come from those trials. My suggestion for now is to keep on respecting the inclusion criteria of the trial.
And would you still go for first-line FOLFOXIRI plus or minus bevacizumab if you have a BRAF mutant V600?
Hans, we need to, you know that I was involved in the TRIBE study as well as in the TRIBE 2. And one of the question coming up with the TRIBE 2 study results, and is actually a question also published in the Lancet of Oncology recently. Should we treat all our BRAF mutated patients with the triplet upfront, given that the subgroup analysis of the TRIBE 2 did not confirm what we observed in the TRIBE? That means, in other words, that we did not observe a huge advantage, a relatively consistent advantage in BRAF mutated patients with a more intensive treatment. I think that here, anyway, we are squeezing too much the data that we have, and we are looking into tiny subgroups with a very high risk of misinterpreting the results. My personal approach is that if I have a patient that deserves a more intensive treatment, if BRAF mutated, and in good clinical conditions, I do have with that BRAF mutation parameter, the positive parameter, I do have an additional reason for treating that patient more intensively. Is not is BRAF mutated, and therefore I need to treat absolutely with the triplet. Especially if the patient is, because that is very common with the BRAF mutation, if it's older, if it's a compromised performance status, if it's a widespread disease, asymptomatic, and with a very high risk of toxicity, I don't think that those patients are good candidates for the triplet, even if BRAF mutated.
And I still remember from one of your talks where you said 1 out of 3 of MSI is BRAF and 1 out of 3 of BRAF is MSI. Huh? So it's the way I can still remember. I hope it's still true what you said at that time. So what do you do if there is someone with MSI high? Would you rather go for immune therapy, or you still believe that the doublet or triplet targeted agents play a role there?
They probably play a role, but that role compared to immunotherapy, and I say that with a kind of relief based on the data that we recently saw virtually at ASCO. Well, those patients would certainly derive more benefit, generally speaking, from checkpoint inhibitors. That is not true, probably. Again, it looks like in this story that is a magic percentage. 1/3 of the MSI high patients, this is independent from BRAF, progress on immunotherapy first line. And that means that immunotherapy is not the magic solution to all our problems. So there is probably a percentage of patients that may deserve to be treated with chemotherapy or with BRAF inhibitors, even if MSI high or mismatch repair deficient. The problem now is to have strong and reliable information from translational programs to allow us to define good guidelines on how to behave. At the moment, for me, the consequences in practice are MSI priority to immunotherapy, BRAF mutated priority to chemotherapy first line, and then at the first progression, BRAF inhibitors, but also a lot of interest in new trials.
Okay, with these last very wise words, I would like to conclude this interview with Fotios. So Fotios, Thank you so much for this great interview. And I think you summarized really well in 10 minutes what is important in BRAF mutated colon cancer. Thank you, Fotios.
Thank you, Hans, for this opportunity. Bye.
It's time for that section that here in Australia we call quick bites, but over in Belgium they call it French fries.
Thank you, Professor Segelov. So we will discuss today the 5 quick bites. And I actually prepared a few very interesting ones. So as you know, from the 22nd June until the 23rd of June, there was the second virtual meeting of the ACR. And I just want to highlight one specific study, which is a phase 1b study with a personalized cancer vaccine combined with the PD-L1 inhibitor atezolizumab. So what they did was they used NGS to identify mutations, and then they predicted the immunogenic neoantigens and then created the vaccine. And very strikingly, the majority of patients, they were able to elicit a specific immune response. So I think it's a very promising approach. Another interesting study published this week in GCO on June the 22nd was a phase 1 trial of a first-in-class ATR inhibitor. So I will present today 2 papers with ATR inhibitors. ATR is actually an enzyme which is activated in response to single-strand breaks. So ATR inhibitors, they can potentiate the effect of DNA cross-linking agents. So this trial that was published in GCO was a trial with the ATR inhibitor M6620, either as monotherapy or in combination with carboplatin. They include 40 patients, 17 mono, 23 in the combo. And I will just share with you one interesting result from one patient with metastatic colon cancer, had ATM loss, and he achieved complete response and had a PFS of 29 months. So I think it's a promising new class of drugs. Another ATR inhibitor was published in the Lancet Oncology on June 15, was called berzosertib plus gemcitabine versus gemcitabine alone in platinum-resistant high-grade serous ovarian cancer. It was a randomized trial with 70 patients, so 70, and the PFS was 22.9 weeks in the combo, so gemcitabine plus the ATR inhibitor, versus 14 weeks for monotherapy. So again, maybe a promising agent, although it was unselected. The fourth quick bite I want to discuss is a phase 2 trial of lenvatinib plus pembro in advanced gastric cancer in first or second line. Only 29 patients included, and 20 out of 29 had an objective response. So it's a promising combination. Finally, we have the BRCA mutated biliary tract cancer published in ESMO Open, June 5th, where they looked in more than 1,000 patients and found 3% of patients with BRCA mutations. Strikingly, there was an association with MSI high and tumors with higher tumor mutational burden. So I think there is a rationale to test targeted therapy in this subgroup for BRCA mutated biliary tract cancer. And now I leave the word again to you, Eva.
And now for my favorite segment, it's
PBS Update. Thanks, Eva. So this week we're looking at levantinib in patients with advanced hepatocellular carcinoma. The PBS really restricts our first-line treatment in Australia up until now to sorafenib. Now it's goodbye sorafenib, hello levantinib, which was shown to have an advantage in this group of patients. Hopefully in the future we'll have IO coming after the results presented at ASCO, but for the time being, it looks like levantinib is a significant option in first-line treatment.
Sadly, we've come to the end of another Oncology Journal Club podcast. So I'd like to wish you a very happy day. It's goodbye from me, Craig.
Me, Eva.
Und me, Hans.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.
Luckily, nobody listens to the end.
Oh, shut up, Gogglebox. Relogolux, Regogolux, Regogolux.
Abiraterone.
Abemaciclib.